Thank you, and good morning to everyone. A quick comment to Joel as well, and I'm grateful for his introduction. But through the center, Joel has really been involved in some important work in galvanizing the people and agencies dedicated to helping members of cultural minority groups in particular heal from traumatic experiences, and it's been a pleasure to be a part of those efforts with him. I have been asked to provide a clinical perspective today, and I would also echo Joel's comments that this clinical perspective is really going to, I hope not, but it may, pale in comparison to the living and breathing stories that the two speakers, Anthony and Atuma, had the courage to share with us today. So I thank both of them as well. Thank you. And I'll go ahead and start then with a definition of trauma, which is fairly broad and I think encompasses many of the experiences that have been described today, but an exposure to an extraordinary stressor followed by intense fear, helplessness, and horror. So clinically in these situations, the primary rule-out diagnosis is going to be post-traumatic stress disorder. We're all familiar with the core symptoms, many of which have been referenced today: hypervigilance, avoidance, reliving, and emotional numbness or detachment. We know that more than half of children who experience a trauma meeting this definition will develop post-traumatic stress disorder. The diagnosis of children is often complex. First of all, exposure really to any significant stressor is likely to have emotional consequences, but with children, this delayed onset following a trauma is very common. We know kids also have difficulty verbalizing their distress, putting it into words, or describing it as a story. There are instances when kids, of course, are told not to talk. And I think it's important as clinicians, or really anyone helping children in these situations, however, to be keenly interested in the unspoken emotional lives of children, which Anthony described, I think, very eloquently today already. Also, the symptoms in general are less discrete, so you'll notice a lot of irritability, impulsivity, interactions with their peers might be problematic, many somatic complaints. So in the school setting, these are often the kids who are showing up in the nurse's office frequently. This idea of conversion is relevant here, so kids who are converting emotional distress into physical problems as a way to communicate their distress. Learning problems can show up as well, and sleep disturbance. A key point here is that it can really mirror or mimic other conditions. So you think about that list of symptoms and how much it overlaps with attention deficit hyperactivity disorder, oppositional defiant disorder, even conduct disorders. So you have to be very careful about distinguishing these conditions. And also reflecting family stressors, which is another point that was mentioned earlier. Often kids are a reflection of things that aren't going well in the family. So we have to tease out what's family related and what might be more individually focused trauma. So the critical question here is whether a person is showing a predictable reaction to extraordinary events or a clinically significant maladjustment. DSM, of course, gives us some objective ways of making that decision. We look at pervasiveness, so are the symptoms occurring across settings, home, school, and community? How frequently are the symptoms present? And then the duration. So if they're not improving within that 1 to 3 month window, we tend to believe that there's a more significant or clinically relevant concern. And also impairment. So for children, kids who are struggling in school with relationships, having limited ability to enjoy life, their affect, for instance, might be quite flat, and also going to the extent of having suicidal thoughts or self-harming behaviors. The qualitative assessment of trauma is equally important, and there are a couple of categories worth mentioning. One would be intentional human trauma, and that can have both acute and chronic forms. So the acute form, a physical assault would be a good example. A sudden death, particularly a death of a loved person in a violent way, would be another example. And then physical abuse and also neglect would qualify as chronic intentional human trauma. Intentional becomes kind of a mushy term in some ways, though. You think about a chemically dependent parent, and is that person, willfully inflicting harm, becomes a debatable question. But what we do know is that people who have experienced the intentional human form of trauma often have the worst prognosis, especially if the trauma has been chronic. And probably the reason for that, and there's a lot of research support for this too, that this kind of trauma really interferes with basic human needs. So your need for dignity and worth and a sense of control, having power over the things that happen to you in your life. And so it's often associated with these massive attempts to protect the psyche and preserve the self. And some of the maladaptive coping responses are listed here. Things like denial and repression, dissociation, identification with the aggressor, and often aggression turned against the self, which can lead to conditions like depression. Unintentional human harm would be accidents. Typically, these are less debilitating, probably because the person can view them as more random or non-personal. Domestic violence, interestingly, can be viewed as both intentional and unintentional. Sometimes in these incidents, the perpetrator of the violence hasn't intended to harm anyone physically, but it can escalate to that point and lead to kind of this double whammy in some respects. Acts of nature would be the other category. A natural disaster, Hurricane Katrina comes to mind, clearly can be devastating, but often the prognosis is better, perceived as kind of an uncontrollable event. Person's less inclined to take personal blame for these types of incidents. But the response to really trauma is due to a lot of intersecting variables. So it can be the person, personality, your own resources, environment, and culture. It's always there's a certain degree of mystery in trying to understand why different people respond to different traumatic events in different ways. And I do have one quick clinical example here. The 35W bridge collapse, I had an occasion to treat two siblings who were on the school bus during that bridge collapse. And they were just a couple years apart. One was a girl, 11, and the boy was 9. The girl was clearly showing a post-traumatic response. The boy had pretty much an indifferent response. I was mainly involved in kind of the stabilization phase of their treatment, but it kind of gave you an indication that kids can take on these experiences differently. Not sure how this may have changed over time for both of them, if the 9-year-old began to present more like the 11-year-old in terms of her symptomology, but that is something that was different, at least in the immediate aftermath of the incident. More on the qualitative assessment, I think one of the most important things that we can do as clinicians or anyone trying to help someone recover from trauma is trying to uncover the personal meaning that they're assigning to the trauma. And an important type of narrative that often emerges would be the survivor's narrative, and some of the internal messages or the self-talk that might be going on in this situation, feeling that people aren't trustworthy, the world is cruel or unsafe, or I'm worthless, I'm helpless, I'm hopeless. And these can lead to, this kind of thinking can lead to problematic behaviors, including isolation and avoidance. Again, these behaviors that are intended to kind of help you survive. And then with kids in particular, it's important to be wary of these cognitive distortions, thinking about what you should have done or shouldn't have done, and feeling like it's your fault. And we kind of had a high-profile media incident recently, received a lot of attention in the media, in I think it was West Palm Beach, Florida, where the boy's father went into the Wendy's restaurant to retrieve a toy from him as part of a meal and was just randomly shot. So you can imagine some of the consequences that's having in this child's psyche, and how could he not think in some way that that may have been his fault, Dad trying to get something for me and then tragically losing his life. This issue has come up a couple times already and probably bears some further attention, but the assessment of dangerousness, trying to predict whether someone will act out violently, and it can be the perpetrator getting engaged in abusive behavior again, or someone who's been victimized trying to get revenge against a perpetrator. And it's always difficult to make these kind of assessments. I think history is probably the best predictor. So if you have someone who has a history of violent acting out, then they have a greater propensity to act that way again. And acts of violence are explosive by definition, so it's always hard to know. But and people who commit them can often conceal their intentions effectively. But there are, three predictors here, the three P's that kind of conspire to form a perfect storm of risk to self or others. And one would be pressure, so stress on the individual, usually environmental kind of demands, pain or emotional turmoil, internalized stress, and then perturbation, which is agitation or energy. So if you have a person who is showing some elevations on all three of these scales here, you should really start thinking seriously about this person's potential to act out violently and then take necessary precautions to protect that person or others. Important, too, to note some of the protective factors in this. I think as a profession, sometimes we are guilty of relentlessly pursuing pathology, which can divert us away from persons' or families' strengths and resources. In a family like Anthony's, clearly there were a lot of strengths and resources that were beneath the surface of all of the violence and upheaval taking place in the family system. There are several factors that can both buffer the impact of trauma and or be incorporated into the recovery process. And the first one would be beliefs about coping. So the person who believes he or she is capable of overcoming adversity, believing that bad things may have happened, but they don't define who I am, this offers some protection in light of a traumatic experience. Perceived social support, more important than actual social support. So if you believe that you're loved and you're cared for, that predicts a better outcome or a better recovery from a traumatic incident. And then three, actual social support or social embeddedness, and this has particular salience with the African American community and African American culture, where often support is derived from informal social networks, extended family, also the faith community, all are traditional means for healing in the African American community. Some cultural implications. I think it's important to note that this violence in the African American community is clearly not occurring in a vacuum, and we know that there's a relatively high stress burden among African Americans. This idea of a persistent sting of racism and poverty. When your livelihood and dignity are constantly under assault, it can take on some explosive characteristics in a household. We know too that there is kind of this double whammy that African Americans, particularly disadvantaged African Americans, are more vulnerable to traumatic incidents, and then even in the recovery process, assuming that they are able to receive help, the demands are higher after the trauma too, so it makes it that much more difficult to recover. The sociologist Amos Wilson offers some comments too on displaced aggression, which I think are probably relevant too. Powerlessness and interpersonal violence are inextricably intertwined. So this idea that it's too risky to attack the people who are really oppressing you. So instead you might redirect hostility towards someone more vulnerable than you, a woman or a child perhaps. Also, the help-seeking patterns that we know about among African American individuals. There is this keep on keeping on ethic, and this idea that you suffer as kind of heroic suffering. John Henry's syndrome has to do with relying on personal resolve to overcome problems, and this can also be born out of this lack of resources and support. So if you don't have helping resources readily available to you, you may be more inclined to rely on your own devices to try to deal with stressors. Also, we know that as a group, African Americans tend to be a group of individuals that can't, don't, or won't seek conventional forms of help, and that has to do to a number of factors, and one would be access. So if transportation, if you don't have a means to get to a clinic to receive help, it's hard to access it. Child care, so how do I get help for one child when I'm trying to watch 4 other ones and not being able to access child care services at a clinic site? And then the lack of culturally competent providers, so it's hard for me to find help from someone who looks like me or is conversant in my cultural experiences. Stigma would be another one, so having low expectations of conventional providers of help, or even negative past experiences. They've kind of been there and done that before with people who misunderstood them or may even have mistreated them in a therapeutic setting. And then the preference for traditional healing practices. So as a group, African Americans may prefer prayer or seeking pastoral care when they encounter psychosocial difficulties. Another point here, the men who commit acts of violence were once boys, so we have to take very seriously how we're socializing and nurturing boys, I think, as a society. And I think there is kind of this self-fulfilling prophecy that black boys are understanding that they're viewed many times with contempt by society, and I think they act accordingly. So I think we have a lot of black boys who have lost hope, and there's probably nothing more destructive than a person who has lost hope. A lot of concern really in the educational domain. I pulled out a couple of statistics here that are relevant. I don't think there's any question that our educational system has underserved black boys. If you take a look at the first statistic here, black males comprising 8% of the U.S. public school population, but 37% of students who are suspended. Black children are 17% of the public school population, but 41% of the children placed in special education, and out of that group, 85% of the black children placed in special education are male. We're well aware that, as a prevailing truth here, the world can be very cruel to people who aren't educated. Your prospects for a fulfilling life go down dramatically if you haven't had an adequate education. And there's a quote here, too, from Nathan and Julia Hare that kind of captures what can happen when you have lack of access to realize your potential. And I'll read it. Blocked from the avenues of social power and interpersonal potency, black boys may too often feel impelled to overcompensate in the physical, and clearly that can have direct relevance to domestic violence. A little more on some of the cultural implications. This is something that I've done kind of informally through my work, but I always ask black males about their futures, even very young ones, and kind of what they're envisioning for themselves. It helps kind of gauge their hope, and it can also become kind of a rallying point for treatment. You can set goals around what they want, and it helps you get buy-in. But some of the popular answers, if you ask many of the black children that I see about what they want to be, they talk about being a pro athlete. They talk about wanting to be a rapper, or a rap entrepreneur is a new one, and I ask what that means. It's a rapper who makes a lot of money. So and I think some of the critical questions we should ask, not that there's anything wrong with aspiring to really any of these professions, but I think we should take a look at how some of these models are treating women and children, and what lessons they are teaching. And I think some of them clearly are that you value material things over people, and that violence is an acceptable way to solve problems. And I think, and this has been also mentioned earlier, but kind of this prevailing image of manhood among young black boys is, how much money do you have, what kind of car do you drive, what kind of clothes do you have, and how much pain can you inflict on others or endure yourself. And clearly that can lead to violent behavior if that's the way that you're viewing the world, or that's your outlook on people. I think it's also important to note, too, these exposure effects. We're learning more about this idea of community violence. So if you're surrounded by violence, what impact does that have on your behavior? And what we're seeing is that there's this strong correlation between viewing violence, either human forms of violence in your home or in your community or even through the media, and then acting violently at some later point. And this correlation is about as strong, we're finding, as the correlation between being exposed to lead and developing mental retardation, and then secondhand smoke exposure and developing cancer. Now, it doesn't mean we should blame the media necessarily. We know that there are countless cases of young black men who are doing well in school and staying out of trouble who have been exposed to violence and not acting violently. But I think if in the absence of other protective factors, I think sometimes these influences can really tip the balance in the wrong direction. Okay, I'm going to have to move through the rest of this fairly quickly. I think I'm running short on time, but I wanted to talk a little bit about early intervention, or kind of a pre-treatment response to helping someone recover from a trauma. First, let me preface it by saying it's always a journey or a process and not a destination, that recovery, and this has been mentioned before, very individualized process, and there's no formula for it. But I think it does start with validation and normalization. Sometimes, both directly and indirectly, we send these messages that, okay, you'll get over it, you should stop dwelling on the past, it's time to get on with your life. And our intent is to be helpful, but it's really based on our own discomfort. We want to push this issue away because it can be frightening or scary for us, or we don't know what to do. Another message we may give is, well, it's good for you to go get help. We have to understand that the person's often too stunned to take that kind of action. They just need a chance, that quiet space to kind of reflect on what's happening to them and begin to sort it out. And that can take a long time for people. I think the more healing message is to help them understand that this is natural for you to feel confused, for you to feel hurt, sad, angry, and to be present for them as they begin this process of trying to make sense out of the experience. I think, plain talk is important especially when you're dealing with kids. The best predictor of how a child's going to react to a trauma is the way the parent reacts. So if the parent reacts in a calm and rational way, the child tends to have a better response. And we have to give permission both to talk and not to talk. So if you're working with a child and he or she's just not prepared to talk, it's important that we, not force it, and that we have the willingness to back off. And then, as Dr. Williams was saying, listen as long as the child wants to talk, once that talking process begins. I think, too, in these situations, really important to provide a clear, specific, declarative statements about what's happening, because if there's a void of information, the kids tend to paint the worst-case scenario. So we have to tell them what's going on. If there's an arrest or some kind of police involvement, if the family's going into a shelter, explain that it's being done for safety. If you have an idea how long the shelter experience might be, provide that information. Another pre-treatment strategy, giving up re-traumatizing behaviors. Very often, and this makes sense, that if you're in a lot of pain, you might resort to some things that are designed to reduce that pain, drug use, sometimes acting out yourself, thrill-seeking. These things all keep you in the survivor mode. However, they allow you to kind of avoid the experience, whatever it is that's causing your distress. They keep you isolated when you need to really be around people and drawing support, and they detach you from your true feelings, or at least being able to confront them. So these things have to be sacrificed really in order to get better. Number 4 is giving up secondary gains. So getting better often means letting go of things that are comfortable or familiar to you. And I think people have to take very seriously this question: what will I lose if I let go of some of the anger or bitterness or resentment that I'm carrying around? And I think sometimes people will hang on to those feelings to preserve a connection to the person who has harmed them. So the person who has harmed them is still loved by them. So they can hang on to these feelings even if that person is absent or that person is not safe to be around. And then sometimes using this motivational interviewing approach, I think this is helpful too. And it's as simple as just taking a piece of paper, dividing it down the middle, and talking about costs and benefits of remaining angry. So if I stay angry, what do I stand to gain? If I stay angry, what do I have to lose? And seeing if that person can then use that information to make a healthy and safe decision. Establishing a safety of climate. A climate of safety, making sure you're taking every step to keep the trauma from happening again, but being careful not to promise safety for a child or for a family. No one's powerful enough to do that, and a lot of that does stem or hinge on the parents, in this case, ability to make good choices and keep kids safe. And we can provide the best therapy in the world, but we don't have any assurance that the parent is going to have the wherewithal to maintain safety. So being careful about promising kids in particular that everything is safe for them. This has been mentioned too, this frustration with parents who continue to expose children to harm, and clearly there are some psychological and economic factors that underlie that, but I think it means that we have to be equally committed to helping the parent. So it's impossible to love and protect someone else as a parent until you first love and protect yourself. This is also a concept that's been thematic today, but balance. And you can't work constantly on difficult material. You find at some stage where people almost get militant about their healing process. It kind of dominates what they do minute by minute. You have to find time, though, in your life for recreation, play, and laughter. And then self-care, I think, is also critical. Getting enough exercise, sleeping well, eating right. I tell kids often that your body can't make the things that you need to be strong out of Oreos and Cheetos, right? So you have to make sure that you're eating properly, because nutrition is going to allow you to withstand difficulty and stress. I'll just touch briefly here on kind of the standard treatment approach, which is cognitive behavioral therapy. It's considered the gold standard. The main focus would be systematic desensitization. It has several steps to it. I'll just kind of highlight these quickly. One would be to recreate the trauma story, then break it into a chain of events. You rate each of those events according to how frightening or how scary they were. You retell the story, again, typically in the context of a safe holding environment like a therapy office, and then apply anxiety-reducing techniques to cope with the recollection of those events. Often there's homework assigned, so some kind of an in vivo procedure. An example might be helping a child gradually approach a room in the house where some domestic violence incident occurred. So the first step might be to sit in that room for 10 seconds, and as the anxiety begins to build, apply a coping strategy like controlled breathing. You breathe in through your nose for a count of 7, hold it for a count of 2, and then release for a count of 9, and then gradually help the child extend the amount of time that he can tolerate that environment. The basic rationale behind the approach, first of all, is to organize the memory. If you can put it into a coherent story, you really gain control over it. If the memory is stored in pieces, which is often the case with trauma, then those memories can intrude and be disruptive in your relationships and your day-to-day affairs. The second thing it's doing here is probably integrating memory and emotion. The feeling then can become kind of a reminder of the event, something that just kind of passes through consciousness, and not become a trigger that signals that the incident is going to occur again, so the person doesn't become flooded by the emotion. And then thirdly, making the intolerable more tolerable. So simple exposure to anxiety gives you some inoculation against it. Okay. I want to talk a little bit about the common factors too. CBT, or cognitive behavioral therapy, is a very structured type of therapy, and it probably leaves some important things out. And one would be relationship influences. So this therapist, again, could be the best practitioner of CBT in the world, but not be real helpful because the person's not able to form this alliance with the person that he or she is trying to treat. The common factors approach tells us that people really get better to the extent that they're able to form reliable, caring, and trusting connections to others. So being able to serve as a buffer or someone's angel. A therapist can do that. Other people can clearly do that, but it is probably the prime agent of change in a helping relationship. The second one would be instilling hope, promoting this idea very early in the treatment process that things can get better and to persist in spite of results. And to me, that's really a question of faith, which is a little bit uncomfortable, I think, for a lot of therapists, this idea of spirituality. But you can think about it really as kind of that guiding force, whatever it is that helps sustain that person's efforts or energy, no matter how bleak circumstances may be. And I think as a profession, we need to do a better job of understanding and tapping into spirituality as a way to help people heal and recover. The next step in common factors is becoming more aware. Spend a lot of time within this perspective, educating people about flight and fight. So telling them that the nervous system has really been tuned up to 10 and someone has taken out the knob. So it's important to help them recognize kind of the physiological cues of their distress and then learning how to manage them. And I mentioned, controlled breathing is one exercise that can be very helpful in trying to reduce the physiological arousal that's often associated with trauma. The next level of awareness is redeploying attention to different ways of feeling, acting, and thinking. For adults, meditation is often useful. It's this idea of a quiet space, just allowing your thoughts to enter your consciousness and your feelings. You accept them, experience them rather than judging them, and then allowing them to float past. For kids, guided imagery is often very helpful. Work with kids on trying to put some of those difficult thoughts and feelings into helium balloons, and then let those helium balloons release, and then that gives you a sense of mastery or control over those feelings. You can teach younger kids particularly how to blow bubbles as a way to kind of teach breathing and relaxation. Progressive muscle relaxation techniques, the idea with the lemon, tell kids that they have a lemon in their hand, they're supposed to squeeze it as tight as they can, and then feel the juice kind of squeeze out onto their hands and fall to the floor floor and now release it, and how good that feels to have that release, or to experience that sense of relaxation. And you can do a similar technique with a jawbreaker gum, chew it, chew it, chew it, and then let go, and then experience how good it feels to kind of let go. Also do some things kind of matching animal imagery to a treatment strategy. So the turtle for young kids can be an example of something that feels good. It feels good to slow down and to relax. The lion, sometimes you have to be brave and face things that scare you. Those kind of symbols can be really powerful and organizing for kids. Corrective experiences would be the next phase of a common factors approach, and this is the idea of doing what one has previously been afraid to do and then realizing that the consequences are not nearly as bad as anticipated. There's a Chinese proverb that I really love that's applicable here, but go toward danger, and that is where you're going to find safety. And we mentioned the survivor mode earlier. Avoiding keeps you in that survivor mode. Approaching something that's feared allows you to move toward feeling. So the goal becomes to connect the painful memories to adaptive behaviors, thoughts, and feelings. And one way to do that, if you were to frame domestic violence as a grief experience, talk to people about what's been lost. And some of the common things they might mention would be the sense of safety and security, the loss of a parent or another caregiver, or the loss of hope. And help them work toward completion versus closure. I think closure is a real problematic term because it's so artificial. You don't take an experience like this and close the chapter on it and have it be done. But completion conveys that it's an often lifelong corrective process. And so grief you can think of as a wish for something more, better, or different. So in the domestic violence context, wishing for more from your family, or something better from a father, or something different from your father or another parent. And the corrective experience becomes storytelling along these themes of more, better, and different. Journaling, drawing, all of those things would be helpful. Forgiveness is probably the ultimate form of completion. It surrenders the pain by loosening its grip on a person, and it's important to keep in mind that you're letting go in forgiveness for your own benefit, not to satisfy a victimizer or to excuse or condone his or her actions. Some other corrective experiences, one would be creating an empowering script, so trying to identify exceptions, so those times when the person was able to fight through anger or sadness and get through the day at work or get through the day at school. Sometimes the miracle question can be a good organizing approach for people who are experiencing a trauma. So if the trauma or the pain, distress were to go away, what would that look like? What would you be doing? And then trying to take the steps necessary to realize that miracle. And then this has also been mentioned, I think it's critical, but trying to find the purpose or the meaning in the suffering or in the trauma is probably a latter stage treatment issue. But what am I supposed to learn from this trauma? I think at some level everyone has to be able to extract that meaning in order to recover it as fully as they can. I'm going to skip over the anger part. And then continued reality testing. So as therapists or other helpers, we want to provide hypotheses that the world may be different from the way that the person believes. We might assign some homework and give the person, again, a chance to practice it in real life, test out these hypotheses. One internal dialogue the person may have is that the world is punishing, so an intervention strategy, send them on a beauty, love, and joy hunt. Take pictures, draw pictures of love, beauty, and joy in the world. Someone who has an internal dialogue focused on themes of helplessness or powerlessness, have them keep track of some of the small victories. So again, getting out of bed that morning when you really didn't feel like it, making that meal for the kids when it was like the last thing on your mind. Those small victories can be used to leverage further change. And then the idea is that as you accumulate more and more of these mastery experiences, it leads to durable change. Just wanted to wrap up with a couple of recommendations, and they both focus on domestic violence as being a systemic problem that requires systemic solutions. So I think, first of all, we need to ensure the availability of a full continuum of services. In the prevention world, I think in schools in particular, we can teach in a very direct way emotional literacy to kids. So how do you solve problems? How do you delay gratification? How do you get along with people who are different from yourself? just resolving conflict, I think, is a topic that all kids could benefit from in school, and we really need to put these kind of lessons on the same par as reading, writing, and arithmetic. If kids don't have the emotional literacy or emotional competence, they're not going to be able to excel in school ultimately anyway. I think there's a lot of exciting work being done around rites of passage, so really taking a look at some of the phases of identity formation for kids and recognize them as they kind of pass through those phases, and also as they're acquiring pro-social skills, so showing respect towards someone else or caring or demonstrating that they're trustworthy. We can kind of operationalize that. And I think parent education, a lot of interesting work clearly being done here at the university, and Ann Manston's concept of ordinary magic, these little things that really aren't so little, and Dr. Williams highlighted several of these as well, but spending time with children, providing adequate supervision and monitoring, maintaining high expectations, and then communicating the boundaries and limits. And then this idea of emotional competent parenting, so being attuned to your own feelings. You're not going to be able to help children function well emotionally until you're functioning well emotionally. Verbalizing your own problem-solving methods as a parent, talking those out so kids can get a sense of how you're trying to navigate your way through difficult situations and problems. And then encouraging your children to talk about their feelings, and then teaching them how to soothe hurt feelings, that the automatic reaction to hurt feelings doesn't have to be hurting someone else. You can rewrite that script. Some of the early intervention ideas, I think mentoring is something that's probably underutilized. We don't have a lot of resources, or as many as we need, in the area of mentoring, but I think it's critical. Someone who's kind of walked through the battle trying to impart some of that wisdom to a younger person. So this idea of reaching back or giving back, I think, is critical. We are fortunate to really have an abundance of support groups in our community. Domestic Violence Project, for example, a BREEZE project offers many for young people that are very effective, and we can utilize those. In therapy, thinking in terms of evidence-based practice, so doing what works and then trying to provide the right treatment to the right person at the right time. We can be more scientifically minded as we provide treatment. And having said that too, this idea of community-defined evidence, that often there are a lot of untapped secrets within underrepresented communities like the African American community that really should be used to inform our knowledge about how to help people heal. So I think we have a responsibility to bring some of those lessons to the surface. And then lastly, I think the importance of integrating systems. So very often the consequences of domestic violence, injuries or emotional difficulties, are first noticed in the primary care setting, a doctor's office, or at school. So I think it's going to be important as we move forward to be able to identify and train people who are kind of on the front lines to be sensitive to domestic violence issues, and then link them to people who can help. So forming these links between the primary care setting and the mental health clinic, or schools in the mental health clinic, or even better, kind of bring those services into places like schools and to primary care settings, so that we can have more of a seamless service delivery system. And I will stop there. Thank you.